Hi everybody, it's Bram Duffee. Welcome back to Health Communication class. This is your first lecture and we're covering chapters 1 through 3. And if you don't have your book yet, don't stress. I assume that by the end of week 2, everybody will have them. And I'm hoping folks aren't spending a lot of money getting the used book. But in addition to the discussion, we also have slides that are uploaded for you in the discussion. And so when we begin this look into chapter 1 and to health communication, I think it's important that we think about preventable illnesses, injuries, and premature deaths, because this preventable stuff and people hurting themselves and dying early, these are categories of things that result from lifestyle choices or a lack of preventative care. So preventative care would be like going to the doctor on a regular basis. And not having that can put a really strong toll on our healthcare system, because when you come to the healthcare system with big problems, they cost a lot more than if you catch them at the bypass first. And the National Safety Council says that poisoning, for example, and you may not think of it, but that's one of the most leading causes of preventable injury-related deaths in the country. And that, of course, includes drug overdoses, but poisoning is a big thing. And so when we think about health communication, there are aspects that lead people to those directions. And there are different things that happen to people with their family, with their society connections, with their job connections, with all of these different things that contribute. Sometimes we may be looking at contributions because of a latchkey kid situation growing up, or maybe the parents just don't know any better. There are lots of different things that the kids don't necessarily get from school or from their parents, but they might be able to pick up from society as a whole through media. So when thinking about that and all of these health issues and how they're related to us, when we kick off preventable deaths, one of the major things as Americans, we know that more than 50% of Americans are severely overweight. And when we use the term obesity, we're really looking at your body mass index. So anyone with a BMI, a body mass index of 30 or higher, is considered to be obese. And so the way that you can easily calculate that is by taking a measurement of your neck plus your height and your weight. And there's an online calculator that you can find to easily be able to figure that out. But if you are under 30, then that doesn't necessarily mean that you're at a healthy weight. It just means that you're not at the obese rate. So the concern with all of that is that right now we have to acknowledge that there's a health campaign out there that says that big is beautiful. And I'm not going to discredit that, but I have to say that big is also unhealthy, and big also results in a faster death. And so we in healthcare have an information battle out there when it comes to what's real and what's not real. And so the BMI is one way of thinking about how it is that someone ends up getting a stroke someday. How does someone end up getting diabetes someday? How do these things come about? And the direct result of the weight is part of it. One thing as a healthcare worker that I realized early on that is just very interesting is about people's body structures. And so I am on 2 different episodes of the TV show My 600-Pound Life as a paramedic with patients. They've got me filmed there. And so not just from that, but in general, I have worked with lots and lots of very overweight individuals. And so I want to mention that, the term big boned, or the term, those kinds of comments that can happen to to be put on to folks who are overweight are just totally inappropriate, because I want to share with you that the structure does not change, you know. So just because someone's larger doesn't mean that they have bones that are, you know, that are different. The same human skeleton is in that is in the body, is in that body. And so that is an extreme amount of stress to put on that structure, you know. And so that's why folks who are overweight have their knees break down and their hips break down, you know, much earlier. And so it's not just that. There's the heart doesn't, you know, if you look at your fist, like by gripping it like this, your fist should represent about the right size for what your heart is, you know, for your body. And so if your body's major BMI still means that that heart has to move fluid throughout that system. So these things are important because we know that society has a perspective on big is beautiful, and yes, that may be true, but at the same time, like I had mentioned, it also is something that has a direct correlation with diabetes and heart disease and early deaths. And so these are a major part of our society. And so I want to encourage you, even if you don't have a BMI of 30 or higher, I want to encourage you to do a personal health inventory and consider doing healthy stuff with me this term as we talk about it and explore that. I just want to share with you that I got to do my gym time today, and I'm not someone who's ever enjoyed going to the gym or lifting weights or any of that, but there are ways to get into it. And the thing that worked for me was that I ended up getting a gym membership that allows me to always have a free buddy pass. And then my best friend, who knows more about working out than I do, goes with me. And we've established this pattern of always going together. And so I can just tell you that me personally, the reason I go to the gym is because I have a best friend that goes with me, you know? Otherwise I would not be going, I would not be held accountable, I would not be successful. So maybe that same kind of thing could work for you. So when we're talking about preventable deaths and we're talking about different aspects of issues that are related to healthcare, the other big one that knocks on the door of our time is vaccines. And I know that when we talk about vaccines, that one of the first things that comes to your mind is COVID and what we just went through. But vaccine preventable diseases are really set up to help, because vaccines work by stimulating our nervous system just so that our nervous system knows to fight. And if it doesn't know what to fight, then we get the disease. And so they figured this out in the 1700s. And so we've been doing vaccines for a very long time. And the number that I saw showed that just for the diphtheria, tetanus, and pertussis shot, the DPT shot, that alone has saved 154 million lives in the past 45 years. So the results of the life-saving measures that we get from vaccines, we don't directly see because it's sort of something that's protected us. And so we don't know what it does. And so the sad thing is to see, you know, suffering and death that is totally preventable. And if you don't, and so one of the controversies first really erupted back in the 1800s. You know, smallpox was going across England and just destroying. And there was a vaccine that was developed, and I think that the vaccine was really successful. And so even then in the 1800s, folks feel like that we're taking away their rights, by trying to force upon them to get this life-saving vaccine. And like we mentioned, a vaccine is something that lets the body know what to fight so that it can't make waves too far into the body. So in the 1800s, there were anti-vaccine brigades. That even was, I think, what the word was, and that has really been something that's gone up and down throughout history. And I think most recently, we all experienced the mess with COVID, but probably the biggest controversy with vaccines that I'm familiar with happened in 1998 when this Dr. Wakefield in the UK put out this study that says that the MMR vaccine causes autism in kids. And when any kind of claim like that gets put out, it makes waves scientifically, and people pay attention and investigate. And so it made publication, and he's saying, hey, this causes autism. And so when the scientific community looked at it, they found that he manipulated data and was not truthful, and the study was a sham. And so this total sham study that could not be reproduced because it was not scientific resulted in him losing his ability to practice medicine. So this happened in 1998. And if you think about it, we're looking at something that happened within some of your lifetimes. Like, some people may be old enough to remember that. And so the effects of that have just really got picked up by conspiracy theorists. And I'll tell you what, there are lots of conspiracy theories out there, and I believe that a lot of conspiracy theories are good to be able to think about so that you can cultivate your critical thinking skills. But at the end of the day, everything in the world has a black and white, like a truth and a not truth. And so when we know that the scientific community has been clear about the answer on this, and yet there are autism forums that are going nonstop, I recognize that as a real health problem, because people are not getting information that's accurate that would help them, and instead they're getting information that could detract and hurt them. And one of the things that is even pushed so far into our political minds today is that John F. Kennedy Jr. is one of the people running for president right now. I think he has like maybe 5% or some kind of in a poll somewhere. But if you look up he's very mainstream, and if you look up his name on the internet, on Wikipedia, one of the first things that it says about him is that he's an American political figure who's a conspiracy theorist. It says that in like the first line, and he really has a thing with pushing vaccines, saying they cause autism. So I'm just here to say that what we communicate matters, because things can be manipulated, and the mistruths can end up hurting people. And we're talking about, in this case, what happens when people aren't able to get vaccines. And in my role as a paramedic, I've seen cases where children get preventable illnesses because of it, and it's just a sad situation to see undue suffering. The other thing to talk about when we look at issues holistically is to think about the cultural, societal paradigm. And we have to be able to think about how issues of power and discrimination and even systemic factors sometimes push away certain groups in society. And so let's talk about smoking, for example. So if we talk about smoking, we have to examine somebody's financial status. And we recognize that financial status will influence the resources and the ability that somebody might have to quit smoking, because it's like tackling a larger problem. It's not just the smoking problem. These disparities in education and in the ability to access the doctor, and so for me to quit smoking, because I smoked cigarettes in the past, for me to quit smoking, I had the knowledge to know better, and I had the society influence to pressure me not to smoke, right? And also I had a ability to get to the doctor and get Chantix, which is a drug that you can take to stop smoking. And so I knew better, I had the knowledge to know better, and I went for help to my doctor to get medicine, and I stopped smoking. And now I've been smoke-free for 20 years. But the only way that it got there is because I knew better and I had the resources. And the thing is that not everybody knows better, or knows on the level of full understanding, right? And these things can make a real difference. And so if our goal is to make sure that everybody in society has proper health care, and can get truth and can be supported, as they tackle their health problems, these are that means that we have to consider how we address people as working as healthcare workers, and how we tackle problems when we put out things through the media, and how people describe their beliefs. In chapter 2, we get into the patient experience, and that refers to the active involvement of how a patient does stuff with their own healthcare decisions. And so there is this paternalistic model where the doctor is the sole authority, and that's the whatever that person says is the way it's going to be. And we've moved into a model where it's much more consumer based and consumer focused. And so what that means is that back in the day, the doctor said, you have to take this medicine to get better, and I need you to stay in the hospital, and I need you to do this treatment, and whatever the doctor says goes. But nowadays, we have to convince people that they even need these drugs, or need these treatments, or need these lifestyle changes. And so this consumer behavior has changed a lot. When we just look at television, we can see advertisements thrown out there for drugs. Now people go to their doctor and say, hey, should I be on this drug, Ozempic, now? Because, I saw this on television. And they go to their doctor proactively sometimes. But these kinds of things have changed so that we are much more informed, but we have less capacity to understand that information. And so that's where, even though the patient is much more in the driver's seat as far as decision making, it just means that the level of responsibility for healthcare providers to communicate has just gotten stronger. There's a couple of examples I want to share with you. And there's this, I'm going to make up a story of Lucy. I'll use Lucy as an example. So let's consider that there's this patient named Lucy, and her doctor prescribed her medicine, and she said, hey, I'm worried about these particular side effects. And so because of the side effects, she is concerned about taking the medicine. So that means that she's not just going to accept the doctor taking the pill and going. She's going to participate in that. Be like, I'm worried about nausea with this, or what about being able to go to the bathroom with this, or whatever the case is, because the doctor has to recognize that the patient needs that medicine. There are some medicines that are preventing someone from, that are preventing people from having major events. And so the patient understanding why they have to take that is important. And so it's like, there's another patient. Let's pretend like there's this guy named Peter, and Peter needs a CT scan. And the doctor says that he needs a CT scan, but he isn't necessarily buying it because he's worried about the money involved. So it's now the responsibility of the healthcare provider to make sure that they understand that the different aspects of this, right? So that the patient can weigh these choices, especially if they don't have insurance. Because a CT scan sometimes is a life-saving tool that we need sometimes during emergencies. The other thing about communication, and this was addressed in chapter 2, happens to do with narratives and communication. And there are different types of narratives that people can go on. And one kind of narrative can be a positive narrative where they think about their story as helping them grow and get better, right? So I have this injury and I'm going to rehab and I'm going to run again and the world's going to be great. That's a narrative that's like a quest narrative where there's a story that the patient's on. There's also a restitution kind of narrative where maybe you have a burn patient who is digging themselves out of a long-term health problem. And so that story of restitution that's in their mind is a motivating factor. These are things that are described by our book to help us see how sometimes patients can use these narratives, use these ways of thinking and talking about their illness and their injury to help them get through it and be successful. One of the things that I think we all think is kind of funny is how we probably notice that older folks talk about their health problems all the time. But the thing is that is their new reality, because at a certain point, our bodies all start to break down. And so these narratives about how the process goes all matter, because sometimes they can lead towards a negative downward spiral if we're not keeping them in the check. So let's look at this from also a patient's perspective, because there are patients that have narratives in a mindset about getting better and moving on, but other times a patient may not be able to handle the stress or the overwhelming complexity of what's happening for their illness, or they may be older and easily confused and have a family member that's in healthcare. There are all kinds of reasons, but sometimes people would rather not know much about their healthcare and push everything over to a loved one to take care of, like a son or a daughter or an aunt, someone else that would be able to make all their decisions for them. Other cases, folks just want to feel good, they are interested in whatever it takes just to feel good, right? They may be in pain, they may be hungry, they may, whatever that is. And so those perspectives have to be understood so that the healthcare provider can address that the right way, because at some point the patient has to understand that what they're doing could kill them, or what they're doing is making the situation worse. So let's say a patient has abdominal pain and we are investigating their abdominal pain. Well, we don't want them to eat or drink anything because of it could mess up the readings on the evaluations that we're doing, and it could also prevent us from doing emergency surgery if we need to do that, if that happens to come up. And so, a temporary hunger that the patient has, we need to talk them out of eating. This is why a lot of times we don't let patients eat in the emergency room. It's because we don't know what procedures that they may need to fix their problem yet. And a lot of surgical procedures definitely require that you not have anything to eat, or it'll delay the procedure. So there are lots of things that happen with patients' preferences that we now take into account that overall add to the patient experience in a way so that, yes, the patient does make a lot more decisions about themselves, but also we see that there are cases where those patients make decisions that are horrible for themselves. And so is it really the patient's fault in all the cases when they don't have money or resources or knowledge or family support or society support? So it's one thing to hand someone as much information as you can, but it's another thing to not give them everything they need to be able to make it successful. So in chapter 3, we talk about direct and indirect kinds of support systems that are out there for help. And there are lay caregivers that are helping their loved ones without making any money, without getting anything for it, but just as a part of the everyday life, working with their loved ones. And so we recognize that there are some challenges that those folks face, because these lay caregivers, they often experience similar levels of suffering and loss, just like the patients that they care for. So, for example, if we consider a daughter that's caring for her mother with Alzheimer's, it's like not only does she have to cope with the physical demands of caregiving, but also the emotional distress of seeing her mother decline. And that daughter might feel a sense of loss in the relationship that they had, a loss of the memories that they had, and even over her own personal time and freedom. So there's a lot that happens, to people in these caregiver spots to put them at a disadvantage. But at the same time, we recognize that direct social support system can make all the difference for that patient. I very much believe that there are patients that can live years and years longer than normal than they would have normally if they have that connection, have that caregiver. And so supportive relationships can encourage healthy behaviors, like somebody that's surrounded by folks that promote exercise and eating healthy and abstaining from smoking. If you have those people around you, then you're more likely to adapt those behaviors yourself also. And so at the same time, social support systems can buffer against stress. So if you're faced with a health crisis, the emotional and practical support from others can help you cope better. And it's just dealing with chronic illnesses and the anxiety about the condition is a normal thing for all of us in life, because almost all of us will end up with those kinds of things. And the particular combination of support system that we get from our family, our society, the connections, even the things that we allow ourselves to engage in, and these all matter. And I had examples of family members who very much are set up like a double-edged sword. I saw this thing on TikTok that reminded me of this class, because it was this lady who was frying up her husband's dinner, and it was just gross because it was so unhealthy. And I was thinking about how this is what she's, feeding her husband. And maybe she's doing that because she loves him and wants him to feel good and, wants him to eat good things, and doesn't recognize she's killing him. That's where the double-edged sword sometimes happens with family support. I know people who are diabetics who have to live in family environments that are just remarkably difficult, because it's the full understanding of the disease and how to eat correctly, and doesn't get through to the right people. And so it's sort of like sitting down to every meal as inappropriate. Every meal is inappropriate. And so it's definitely, as much as a family member or a family support can happen, the opposite can happen too with families. And so as healthcare providers, we have to understand that, and so that we can look at this from different perspectives. So here's another perspective. Let's say we have a young adult that has diabetes, and they feel like they're overburdened because of their parents' constant monitoring of their diet, insulin levels, right? You would think, oh, I'm a good parent, I'm watching everything so tightly. But in that case, maybe the support from the family, even though it's well-intentioned, might feel more like control, and that control could cause the teenager to rebel, and then that tension might undermine their self-management efforts. So we can love somebody to death, or we can hurt them. There's all kinds of ways that we can influence others, especially those who are our best friends, who are our roommates, who are our family members. And so this is part of the scope of the topics that we are going to get to dive into in this class. And again, as part of this, I want to encourage you to think about your own exercise routine, and definitely consider buddying up and going with someone. And the partnership method to pull it off can make all the difference in the world, from accountability to also learning exercises together. And then the way it worked in my world is that it ended up being fun. And so that's the time that I spent with my best friend, and our time that we are able to talk about our lives together, and also the time that we're able to be healthy. So all these things contribute to health, because we recognize that communication is not something that just happens from one person to the other. It happens on a dynamic scale, and it involves aspects from media, society, culture, politics, people's belief systems, and religious backgrounds. All of these things come into play. And so as we dive into this, and as we explore this together, I want to encourage you to keep an open mind. And as we kick off this first week, the final reminder is that your first post is due by Friday, and your final post for the week, each week, will be due by Tuesday as we get going. And if you need me, you know where I'm at the bduffie@kennesaw.edu email address. I'm easily reached there, but let's make sure to reach me through that instead of the D2L system. So email me directly. I look forward to looking at your work this week and seeing how the class launches. So welcome to class, everybody, and congrats on finishing the first lecture with me.